Hi, it gives me great pleasure to welcome you all to this PCR webinar from Glasgow in Scotland on how an integrated OCT X-ray imaging workflow in your cath lab can improve your procedural planning and outcome when treating calcified lesions. My name is Stuart Watkins. I'm an interventional cardiologist at the West of Scotland Regional Heart and Lung Centre. That's based at the Golden Jubilee National Hospital in Glasgow. I also work at Glasgow Royal Infirmary. I'd like to introduce our panellists for this evening, though neither of whom really need any introduction. Dr. Giulio Guagliami, Director of Interventional Cardiology in Bergamo, Italy, and his colleague, Dr. Paolo Canova. We've got a real Scottish-Italian connection here, given Italy's recent success in the Football European Championships and Scotland's success in qualifying for the first major tournament in over 22 years. So a big achievement for both countries. So both Giulio and Paolo are experts in complex coronary intervention and intravascular coronary imaging, and are therefore well suited for the recorded case that was performed by myself and Dr. Margaret McIntyre that we're about to show you. I'd like to thank PCR for hosting this evening's session. I'd also like to thank GE and Abbott for their vital sponsorship. Now I'll just show you our objectives for this evening. I'll move on to the next slide. So we hope to get insights on how imaging can support clinical decision-making in calcified lesions using a structured workflow. We want to share experience between peers and experts on optimal procedural planning and treatment through our recorded case discussion in a patient with calcified disease. We also hope to learn about how artificial intelligence-based workflows can support clinical decision and help maintain low radiation dose for complex cases. We also highlight the use of stent enhancement techniques to safely treat calcified coronary lesions. So during the recorded case presentation, we'll pause to discuss our strategy with our panelists after the angiographic images and also the OCT runs. And thereafter, we will discuss some new advances in OCT imaging before we go through any questions and comments which arise from the audience. And you can do this through the chat function on the screen before you. So without further ado, can we start the recorded case, please?
Hi, welcome to Cath Lab 5 in the Golden Jubilee National Hospital. It's a great honour to be asked to do a case presentation today. I'm joined with my colleague, Dr. Margaret McIntyre, one of the interventional cardiologists here. I'm Stuart Watkins, one of the other interventional cardiologists. We've got a great team today. We have our two Cath Lab nurses, Elizabeth and Lisa. We have our physiologist, Emma, and we also have our radiographer, Nicola, in the cath lab for today's case. So to start with, I'll just present the case. So this is our patient. He is an 85-year-old man. He's quite interesting in that he was in Cape Town in 1967 when the first heart transplant was performed by Christian Barnard at Groote Schuur Hospital. So I guess he does have some sort of cardiology, if not remote, background. His own background, he has hypertension, he's an ex-smoker, he has atrial fibrillation, for which he normally takes apixaban, though he stopped us a couple of days ago in preparation for this case. He has a degree of chronic kidney disease. His most recent EGFR was 56. He has a colovesical fistula, which is historic and doesn't cause him much in the way of problems, certainly doesn't cause him any bleeding. He has osteoarthritis, he's had bilateral knee replacements. And of note for the case today, he does have quite a marked benign essential tremor affecting both of his arms. We'll go to the next slide. He describes fairly frequent angina. We call this CCS class 3. He gets angina and walking less than 50 yards, and this is it's been escalating over the past couple of years. He also complains of shortness of breath on exertion. Now, he has had a transthoracic echo performed, and this has shown that he has moderate aortic stenosis. His peak gradient is 32 with a mean gradient of 20. His valve area comes out at 1.18 with a continuity ratio of 3.27. He does, however, have good LV function and mild left ventricular hypertrophy.
Okay, nice. So this is a LEO caudal view. You can see quite clearly we've got significant distal left main bifurcation disease. take a couple more shots, then we can talk through the pictures in more detail. Quite clearly see the calcium and the LED there before we inject, extending back into the distal left main. It's now in the areocranial. Again, before injection, you can see the calcium in the wall of the vessel. And we'll finish off with a second caudal view for our setup shots. Okay, good. You happy with those, Stuart? Do you want a PA caudal as well?
Yeah, I think so. Yeah, or a 10-35 cranial too, maybe. Just to...
Okay, great.
I mean, things haven't really progressed, have they? Much since in the last year.
So just we'll talk through the angiogram, and then we'll just talk about the kind of discussions around this case, Stuart.
Okay, Paolo, not exactly the coronary arteries you'd like to encounter at 5 o'clock on a Friday night. However, we are increasingly having to deal with this pattern of coronary disease as our population gets older. How would you tackle this case, given our patient has angina despite optimal medical therapy, and bypass surgery really isn't an option?
Okay, thank you. First of all, I want to thank you, Stuart, Margaret, all the PCR staff for hosting me in this cool webinar. I think that you really shows a challenging case due to the huge calcification in LAD. Apparently not calcification in CIRC, even if I wouldn't be surprised to find significant calcification by imaging in this case. And you choose a case with not one, but two bifurcation. So as we say, I think we have lots of meat on the fire in this case. But at the same time, I think that this is a typical case where really imaging can give us golden information. We want to know, of course, everything about the calcification of this 85-year-old man. I would like to know everything about the calcium distribution in terms of arcs, calcium location in terms of superficial or deep calcium, and everything about the calcium thickness. And all this information, I think that only an imaging catheter as OCT can give you. Speaking about and with all this information, of course, you can select the right device to prepare your calcified plaque. And speaking about the bifurcation, of course, my strategy for LAD diagonal would be a keep it open strategy. I would like to implant two stents in those kind of bifurcation. While speaking about the left main, I would like to interrogate imaging to plan my strategy. I mean that if by imaging I have a good ostium of the circ, which of course is involved by pathology, but if I can measure a minimal lumen area more than 4.5 millimeter, and if I can find a safe landing zone in the proximal circ, which it means in my mind to visualize an EEL by OCT, of course, my strategy can be that one to stent the circ from the obtuse marginal till the proximal part of the circ, not to the ostium, so a provisional stenting, standing left main toward the LAD. And of course, after you check your result with imaging, if you have a suboptimal result, you can change the strategy and go for a tap technique for this kind of situation. If the imaging reveal me that there is not a good lumen at the level of the ostium of the circ, and we don't have in this diffuse pathology a safer landing zone of the circ, of course, I will choose a double stent strategy in this kind of situation. And a decay crash, I think, is suitable, but in this case, also a cool-off technique can be a good solution. On our side, I think that we have the recent ABC main trial just published, which say us that both the strategy, provisional or two-stent technique, are comparable. Of course, there is some benefit, a little benefit with a provisional, but statistically not a significant difference.
That's a great answer. Thanks very much, Paolo. Okay, in the interest of time, we'll just go on and play the next section of the recorded case, please.
Stuart, so we've obviously, before we've put this patient on the table, we've looked at the angiograms in detail and we've talked through all the options available and all the eventualities that we might encounter during the case. So do you want to tell us what our thoughts are about the strategy of how to approach the case?
Yeah, so I think the left, as you said, the left main bifurcation is a Medina 111. He's also got bifurcations in the LED and the obtuse marginal. So the second obtuse marginal appears to be the larger of the vessels, and there's a nice landing zone there for stenting. So we're thinking of stenting from the obtuse marginal back into the proximal circumflex under OCT guidance. And we're also going to do an OCT run in the LED, again from where that septal perforator came off, stent back to the proximal vessel with calcium modification, first of all, and then complete the case with a clot of the left main bifurcation. So we're ready to go. So we're going to do an acquisition for angio-coreg.
Interesting. You see the catheter had migrated itself forward a little bit. Do you see that before we started? But we know we're going to try and do a run into the LED as well, so we won't necessarily need to repeat that. It will give us a lot of information about the circ and a little bit about the distal left main, hopefully.
Okay, good. So I'll just take this back.
So ECG, he's obviously aware of the angiogram, but the ECG looks fine and his blood pressure is fine.
You okay, sir?
To give him 2.5 of morphine. Okay, so Ines, do you want to talk us through what you're doing at the back there?
Yes, so I'm just co-regging the OCT with the angio that was acquired whilst we did the run.
You okay?
So with the new system, Ultron, we place it proximally to distally, and then we click confirm.
Okay, that'll settle down, sir. We'll give you some painkiller. It's got a lot of pain, actually.
And then we go to the morphology screen, where we can run through the run. Sorry, let me just press play here. We can look at it all. If you want to see the co-reg, you just click here and we can see them in... It's not.
You can see the
Sound like a nice landing
external elastic lamina. You can see you're now coming into disease segment. You can see there's 180 degrees of calcium there, just in the distal left main stem. Quite heavy disease as you head into the left circumflex. Again, fibrocalcific plaque. And as you head further down, patchy calcification, severe disease. We've just gone past that early first obtuse marginal. Again, severe disease here. Quite a fibrous looking lesion as well, isn't it? There is areas of calcification. You can see around this area there's quite a lot of calcification.
So it looks like most of the calcium in the circ's less than 180s, isn't it?
It does, yeah.
There's this quite dense bit here, just down at the second bifurcation.
Yeah, so we're using the MLD max algorithm. So M standing for morphology, then lesion length, and then diameter is the MLD. So we've looked at morphology. We know it's fibrocalcific plaque. We're now going to go on to the length. So in this screen here, we're able to choose our landing zones. So I think, first of all, we're going to put a pinning stent in the circumflex. So we'll maybe move our proximal landing zone into the proximal circumflex. Now, we'll probably place this prior to the first obtuse marginal so we don't end up putting 2 layers of metal over the
either
obtuse
before
marginal.
it or after it. So Ines, do you want to show us, with the this is the beauty of the co-registration, isn't it? So if we scroll down to where we see that obtuse marginal, keep going, we should see it come in on the OCT. I think it was quite, there it is there, isn't it?
And it's highlighted by this marker here.
Yeah, so if you measure that distance to the distal landing zone, Ines, from where you just put that dot down.
So we're saying this is the proximal landing zone here.
So, yep, so that's distal to the OM, so
Yep.
that gives us a 38. So you could go with a 38 and then use the second stent across the...
Yeah.
And then looking at the distal landing zone then, so you're looking...
What we think about the morphology in terms of what calcium modification we need to perform in the circumflex. It looks like it's almost all less than 180, Stuart. It does look a bit thick at points.
It does, doesn't it? And fairly nodular, isn't it? It's not. So I think maybe an upfront scoring balloon might be a reasonable strategy here.
Yeah, I think that's right.
As opposed to any. So I think we might need some more heavy duty.
In the left main bifurcation.
Yeah, absolutely.
And the LED.
Than the circumflex.
Okay.
But I think for the circumflex, I think non-compliant balloon or scoring balloon would be a good first.
I think so.
Good first option.
So we go on and do the OCT and the LED. Okay, so now we're going to do the second OCT run and the LED back to left main. We'll see how we get on. We're kind of anticipating here that the way the wire behaved, that we might struggle even to get a balloon across that mid-LED lesion, never mind the OCT catheter. But even if we can see some of the proximal vessel in the left main, that would be helpful. So you can see the front part of the catheter is entering that severe area of disease.
Yeah, I have to say it's very, very difficult.
So we can even go from there because we'll see the left main bifurcation, I think. If we go down to the caudal view, we're probably further than we think we are.
Just got a little bit of sustained pressure on there, but...
Yeah.
I mean, the OCT is quite trackable, but it just won't go any further.
I think we'll struggle to get balloons across that, never mind the OCT.
Yeah, absolutely. Okay, can we swap to the bigger syringe, please?
Do you want to come down to the caudal view again, Nicola, P caudal? Yeah, all this thing. So again, you see the left main here, looks healthy in the proximal to mid left main. As we come towards the distal left main, you see the vessel taper down as the disease becomes progressively severe, and that's as into the bifurcation. And we see it as now entering the proximal LED. So, and if you let me see that area that you can see in the longitudinal that's highlighting the calcium for us, with the orange bar. Can we have a wee focal look around that area, see what we think? Okay, so we've got kind of two segments. You see there's a break in the orange arc, but if you look carefully, that's because we've got wire artifact in that segment of the vessel, so it's probably contiguous, isn't it? So if we add these two arcs up, we're going to be at 200 degrees, yeah. So I think it looks like we've got concentric calcium in the distal left main.
Yep.
Okay, Julio. Sadly, the LED calcification and tortuosity was such that we couldn't achieve intravascular imaging with the LED, apart from just its ostium. But needless to say, the LED is a severely calcified vessel. However, we did achieve good OCT imaging of the left circumflex and the left main arteries. Can you just tell me, how would you interpret these images using the new Ultron artificial intelligence software and using the MLD math algorithm, and how will this help plan this gentleman's care?
So, Stuart, I think that is a great example of the type of patients we are dealing with every day on the table. So the severe calcification is extremely challenging in giving some chance to interrogate the vessel. Here is the pullback you did on the circ. And let's spend a little bit of time for explaining to the people that are not so familiar with this new technology and the display, what you can get. Here you can see the display is quite different compared to the usual one, and is going step by step. It has been shown the value of detecting the content, what we call morphology. Here you have the run with the morphology. So because as a first, we wanted to know about the content. And this is a slide showing 3 freeze frame of what you get into the circ at a different point. Let me make this clear. So you have around each cross-section, you have highlighted in orange the segment of the circumference where the augmented reality detecting the calcium. And where the calcium is not detecting, you don't have the orange. And then you have, with a arrowhead, pinpoint the level where the thickness is at the maximum. And you have the full numbers. So it means that you know exactly how much calcium you have in each section, and you know exactly how much is the thickness of the calcium. Here you have 3 sections. The first that is at the level on the left side, at the level of the left main. We can see some calcium is no more than 180 degrees, and the thickness is quite significant, but no dramatic. In the middle portion of the circle, where you have the second marker, you was commenting about the deep calcium that does not need a lot of preparation. And then we are moving on the right side to the distal part that you nicely comment in terms we need more lesion preparation because there is a more larger calcium encircling the vessel, and in addition there is also more thickness at this level. So I think all these information were translated in practice. This is for morphology. Then you move to sizing. In the upper part of your screen, you can see the different chapter that you can click on to be informed on what to do. And sizing is to take the advantage of the automatic detection of the EL. You can see on below the slide, you have this automatic lumen profile, and then you have a thin line. The thin white line is identify where the EL can be automatically detected. And so you can see that there are segments where the EL is visible, and for each section you have the value of the lumen and the EL, and there are other segments where the EEL is not visible. Here the sum up. Here you can see on the left side the detection of the automatic EL at the left main, and you know that is 5.3. Then you can see at the maximum of the stenotic segment in the circle that you don't have enough arc of the EL, is only one segment, too small to measure the EL on the two opposite sides of more than 180 degrees, and then you have the lumen. And finally, you have in between some identification of the EL that can guide you on sizes of the stent inside the circle. So based upon all these aspects, you are taking decision. That is what we would like to have by using this new AE software.
Okay, that's brilliant, Giulio. Thanks very much. Okay, we'll now show the rest of the case, please.
So obviously it's vital in the left main bifurcation that we adequately treat that calcium before we proceed to stenting to make sure we get good stent expansion. So I think in this situation, I would probably be looking to use IVL in that segment. What do you think, Stuart?
Yeah, I think IVL would be nice, as long as we can get it down there. I think we might have to pre-dilate to deliver IVL.
Yeah.
Okay, so after the non-compliant balloon, the long stents, that's a 38mm Zion, so it actually tracked very easily. So that's our 2.5 stent going up.
That's okay.
Take that to 14 atmospheres. And it looks actually a good size distally, doesn't it?
It does.
And the expansion looks
Expansion's not bad.
good. Yeah.
So what we'll do is bring the balloon back a bit, and we'll go to higher pressure, just to, because you can see the kind of some constrainment of the proximal third of that stent. But I only went to 12-14 atmospheres there just to protect the distal edge of the stent. And we're obviously going to post-dilate this as well, so that's at 18 there. Okay.
So I suspect this might struggle, but
I agree.
hopefully
Agree.
it will behave.
Oh, there we go. Oh. Pleasant surprise.
There you go. Okay, so that's a nice place to start,
there.
I think. Yeah.
Fantastic.
So you can see quite a long segment of disease here.
Yeah.
Store. Okay. So what do you think next, Margaret, for this segment?
Yeah, so it's whether we want to try and get another OCT run to assess the calcium, or we're pragmatic about it. So this is going to be the problem, this area here, isn't it? So look at this.
I suspect OCT won't track there.
I agree, especially around there. Look at that. Okay,
yeah.
So you can really clearly see the encasing calcium in that segment. It's angiographically definitively severe. So I think what we do is progressive balloon dilatation in IVL. If we can get it to track down to that segment, you see there's an angulation issue where the severe. It's often interesting how that's often the case. The severe calcium is at the location of the severe tortuosity.
Yeah, that's right.
With the flow dynamics. So that's me up to 20 atmospheres, but it's a small balloon, so we're going to progressively work our way up. So do you want to see if that previously used 2.5 NCB will track?
Yeah, you can see it's still constrained, can't you? Ostally.
Okay, so we'll come halfway back again. So the second half of the balloon's adequately expanded. Okay, so what we should do here is look at this in two views, shouldn't we, to make sure it's expanding and everything else. So hit the pedal there, Stuart. Okay, so that looks up. So Nicola, flip down to the areocaudal thing.
Still constrained in the centre there, though, isn't it?
Hopefully we'll be able to get the shockwave into that.
Yeah, I think now.
Okay, so there you go. So this idea of if you're going to use pre-dilatation to decide whether you've adequately modified your calcium, you should always look in two views to make sure you're not missing the fact that it's under expanded in one view.
That's good.
Okay, so next step, shockwave, Stuart, do you think?
I think so. I think a 3.0 shockwave, you say, so we can use it in the left main stem as well. Would be a good idea. Now, obviously, you get 80 pulses with the shockwave balloon. They all come in 12mm sizes, so we'll have to. We may need two, but we'll try and use one just for
so let's have the 3.0 shockwave.
Fiscal responsibility.
Okay, nice.
Okay to that point. Go to the areocranial now, please.
Fantastic.
I'll just follow this down. Yeah, so it stopped right at the area where the non-compliant balloon wasn't fully.
Okay, there you go.
Oh, it's going to go.
There you go, yeah. So that's, I suppose, the main bit we want to.
Yeah, I think I'm having to push quite hard there, Margaret.
There you go.
I think
it's jumped on.
I don't think we really need to go much further than that, do we? I think we just save. As I say, we've only got 80 pulses. They come in bursts of 10.
Save the therapy. Okay, so we give 10 there and see how we feel, and then we can creep our way back.
Yep.
Okay, so what I'm going to do here is I'm going to go up to 4 atmospheres. Stuart's going to fluoro check the balloons up. It is, and then he's going to deliver therapy. So all he has to do is press that button on the top of the wand, and you'll see on you can see in the console it counts down.
6 atmospheres.
Okay, and then all 10 are delivered. I go to 6 just to push the plaque back, and then deflate. So look to me that store that, thanks. It looked to me like the distal end of the balloon was up, but the proximal half wasn't. So if we keep it back a marker or two, just to center that.
Slightly, yeah.
Good.
Yeah, that's good there. So 4 atmospheres again. Okay, again, I'm pressing the button on the shockwave device. Sometimes if you look at the physiology, you get shock topics, and you see we've had a couple there. 6 atmospheres.
Okay, and then let's look at that again, Stuart.
Down, store that, thanks. Looks a bit better, doesn't it?
Yeah, maybe one more there.
Maybe one more, the exact same place. Yeah, I think so.
Okay.
I'll just take the balloon down for a second, give them some perfusion. So you might not like this, as this will be blocking the left main. So 6 atmospheres and down. Looks well up, Margaret.
Right, let's start with OCT then.
The catheter isn't.
Yeah, Stuart pushed to that wee bit too far, eh?
Imaging catheter has failed. Really?
Okay.
Oh, surprised. Can you try again, or is it?
I guess.
I think.
Take it out. Yeah.
We need to connect a new catheter.
Oh. Really?
Too much time at the gym.
Surprised. I've never had that before. Okay, so
there.
pre-delete there.
So again, distally, I'm not going to go crazy. I just want to make sure the balloon's up.
Looks fine.
Yeah,
Store
so
that,
that's just
thanks.
10 atmospheres. I don't want to cause propagated dissection downstream. That looks nice. 12.
Great, yeah. And this is our area of interest.
Okay,
Well,
that looks pretty
a
good.
lot
Yeah.
better, Margaret, doesn't it?
Yeah, it's proximal, but it's a wee bit. But
Yeah.
see, you can appreciate that really dense, thick shelf of calcium
Yeah,
up there. See that?
You don't
But-
need OCT to tell you this is
No.
calcified, do you?
But some of that's going to be deep into the vessel wall, and it hopefully shouldn't affect our luminal areas once we've stented.
Yeah, so I'm just going to push my LED wire further down. Just managed to creep back
Into one of these septals.
these septal perforators.
There we go.
So the wire's a bit better now. You can see even there.
Yep, so Stuart's just taking this time, letting the stent creep, and I mean, it's remarkable really, 38mm stent. You can see it making its way beautifully down through that vessel.
Wow.
Okay, so we picked our angiographic
That's
landing
good.
zone as that septal perforator, Stuart, didn't? That's good. So
Okay.
very slight constraint just in that area, but nothing that we won't be able to deal with, I think, with non-compliance. I'm deliberately only at 12 atmospheres for the distal edge. So what Stuart will do now is just creep the balloon back a bit, and I'll give it a bit higher.
So this will give us an opportunity to use stent viz. So
Yep.
this is a Innova IGS 520 cath lab. We've got the new PCI Assist software in the cath lab, and the PCI Assist, it's got two components. It's
So
got
if you
stent viz and
okay,
stent
we'll
vessel
take,
viz. Stent viz, other systems is known as stent boost. Can show the metal of the stent very clearly, especially in a calcified case like this, where we want to make sure we've got overlap with the stent and the circumflex. This will make sure that we're in the right place. So we'll just center up. You can see we've got a nice small. So it's very important you see both dots of the balloon, because that's what guides the elastic registration for the PCI Assist software. So looking there, I might just go in a dot, Margaret. What do you think?
Yeah. I think
Certainly
you're
got enough
probably in,
length.
I think.
Okay, can we just center that just so we see the proximal dot? That's good. Okay, so stent viz on. Okay, so it's 30 frames acquisition. You
Lovely,
can see there
yeah.
a really nice image where you can see we're nicely overlapped
You can
with
probably
the
creep back
stent
a
and the
bit.
circumflex. Could even come back a
Yeah,
dot.
back
What
a
do you
marker,
think?
I think so.
Just
Give
to
us
make
more
sure
room for our
we've got
pot.
enough room for the pot, as you say. Okay, so I've just pulled that back slightly.
A lovely expansion.
Yeah, it's come up nicely. Certainly was the less calcified of the two vessels.
Yeah, so that's
Store
14.
that.
Okay, so now I'm going to give Stuart a 458 for his pot.
For our proximal optimization. So stent viz is excellent for these cases, so we're going to park the distal marker in the carina, and can we just cone in round there and we'll do a stent viz just to make sure we're in a nice position. So I'll give a little puff of contrast just to check that we're not way into the circumflex. That looks quite nice actually,
That's
Margaret.
quite nice, yeah.
Okay, can we do a stent viz there? That's great.
That's good. You happy?
Oh, that's great. Okay, good.
It's a beautiful image of the water
Yeah.
crossing of the wires.
That's
Showing us-
nice. So just low pressure.
Yeah, just 10.
12.
We're just
Store
looking
that,
to
thanks.
pose it. We're not.
And we're just going to come back a dot just to make sure that
Yeah.
the first strut's not. We go subliminal
Yeah.
behind the first strut. That's good.
So you see, Stuart's got this careful, constant pressure, and it's gone in.
Yeah. So maybe we can check on the
Cranial,
here.
yeah. You want to take your trapped wires out?
Yeah, let's do some wire removal. I think that looks better, Margaret.
I like that as well. Okay, you ready?
Oh yeah, so there we go. Perfect. Okay, we're just going to go up with the stent now. Our wires are out.
Nice expansion.
Nice expansion, that's great. Okay, 14 atmospheres. Store that, thanks.
Okay, so we'll take that 4, 5, 8 balloon to do a pot, and then the plan will be to rewire the circ.
We're going to do the proximal optimization. Again, it's really important we do this to avoid abdominal rewiring. And when we do come to rewiring the circumflex, we want to, on this occasion, aim for a mid to distal cell. It's not quite so imperative that we're very distal on this occasion.
What balloons would you use for your kissing here, Stuart?
I think 2, 3, 5, 12 non-compliant balloons will be.
That's good.
That's nice. We're going to go there, so.
Again, don't need to necessarily be too high, it's 12.
Great.
Okay.
And I'll maybe do one more, just make sure we come to the proximal struts. I think at this occasion, Margaret, might do a stent vessel visit at this point.
Yeah,
just
good idea, yeah.
Check our situation. So stent vessel vis involves administering contrast as well as doing an acquisition for a stent vis. So we're all set up for that now. We'll do our acquisition, and the software actually tells us when to inject contrast. So I've injected the contrast now. You can see there in the stent vis images, the proximal edge of the stent needs to come up slightly.
Yeah, perfect position though.
You can see here in the stent, it's a beautiful stent
and
vessel vis image,
look,
isn't it?
And even before our kissing balloons, we've got a fantastic result angiographically on the bifurcation. The
carina looks great. So our balloon's in the actual perfect position. So we'll take that 4, 5 up for our pot. So that looks nice. You can go 16 somewhere there, that's fine. Okay, you can open out the cones now.
Okay, we'll have a fresh wire.
So I think there must be a little intermediate branch it's trying to get into there.
Yeah, had a Theo, did we bin it?
Seems to be curling up into the LED.
Okay.
And there we go, that's a fairly distal cell.
Yeah, just give us a fresh
the angioplasty gods are being good to us. We've got a nice J on our wire.
Good job.
That looks fine.
So we're going to take a 3O balloon and open those struts, and then we're going to use our 2 non-compliance for the kiss.
That's coming up very nicely.
That was 16 there.
But now the stents are in, you can really get see the calcification in the vessel very, very clearly.
So the patient can feel us doing these post-dilatations. That's often the case in these patients. We've had to do a lot of modifications, a lot of calcium in the vessel wall. So I think the important thing is to get a good result, but don't push too far or too hard.
Yeah, that's right.
These vessels can be quite vulnerable at this stage in the case.
I think as you're doing slow inflations is important as well. Don't just go straight up to 20 atmospheres.
Yeah. And watch the expansion of the balloon. Don't, see patient can feel us pushing against the calcium. So I'm just a 16 there. I'm not going to go crazy.
Okay, go PA caudal please, and we'll do the kissing balloon inflation.
We can do our imaging and assess whether we need more.
Beautiful.
And 1, 2, 3.
We both come down exactly together.
Nice. So now there's different ways people like to do things.
So this is us really trying to optimize our result here. So it's really, really important that we don't have edge dissections, that we've got the stent perfectly opposed to the vessel wall, and our expansion is good as well. So we know that if you don't optimize these things, then you are at risk of stent thrombosis and the development of in-stent restenosis, and that obviously leads to target lesion failure. So it's very, very important that we take our time at this point to make sure we get a nice result.
Okay, a wee perch.
Yeah, you can see there's a little bit of blood in the catheter there.
Begin pullback sequence.
Begin pullback, yep.
We're just coming in now.
A bit of slow flow, isn't there, distally?
Yeah, there is. Okay,
probably
so
needed a manual OCT run there, would have been preferable. I think that really caught us by surprise, Margaret, didn't it? Really, I wasn't expecting that.
But that often happens in these types of cases.
Yeah.
Great.
Very nice.
Okay, good. So the catheter was just beyond the stent edge. Nice step down into the distal
The
vessel and obtuse
angiography is looking
marginal.
great.
You can see we've held on to our first obtuse marginal, which is
All the
great.
branches, not
All the
not a
branches are
single
there.
branch.
So that all looks fine. But we'll see what the OCT tells us, because that's going
I
to give
think
us
possibly we're going to
more
get a bit of
information.
a pot at the front. We'll see, just on the flyby.
It all looks good. There's no dissections there.
Okay.
And then
Can we turn the dots off if possible?
you can, Stuart. So we just press this button here to remove the AI.
That's good. Okay.
Um,
So that's us down at the distal edge. So you can see there's a lot of swirl there. Can you just go down into the normal vessel? So normal vessel is there.
Yeah.
So I don't see any edge
They're down,
dissections.
so
Can you come back for us?
yeah.
So
That
that's
looks
Might
also
good
just
to
good.
minimize
me.
this so we can see it bigger on the actual
Yeah, I
view,
think it
if
looks
that's
okay.
Yeah, that's good.
Yeah.
So a little bit of swirl,
Yeah.
but certainly good expansion down there. And it looks nice and circular.
And then
So as
coming
we just
back through
come
the vessel, we'll
That
just
all
check
looks
that
great.
there's no protrusion or anything.
Yeah. So that's good. Struts
Certainly
are all well
all
opposed,
opposed,
aren't
yeah.
they? Little side branch coming off there.
And we can see our expansion is the AI is very happy with our expansion.
It is.
And as we come more proximally,
That all looks
Looks
great,
very
doesn't it?
nice.
There's a side
Yeah.
branch coming in.
that's our, just gone past
Our
our double
OM.
layer of
Yeah,
struts.
yeah, I saw that.
And again,
Another
there's a
side
side
branch.
branch there.
And there's our left main
Yeah.
bifurcation. So let's have a closer look at the left main bifurcation there, Dennis.
So you
Yeah.
can see the two wires
So
in the
just
left
going to
main.
go all the way back, and then we're going to have a look. So I'm going to put the AI back on, if that's okay, Stuart, so we can see what it's picked up. So there's some areas of malapposition on the
Okay.
yellow bar here,
Yep.
and one area of under expansion.
So you'll see quite helpfully at the bottom of the screen, there's this color-coded areas of expansion. Our threshold is set at the moment of over 80%, which we use for our calcium cases. Non-calcium cases, maybe 90%, but we've set the machine at 80%. And then you can see our apposition threshold was set as 0.3 millimeters for
Yeah.
malapposition. So it very helpfully color codes that for you, as Ennis is demonstrating.
And as you're looking at it here, it's highlighting an area of malapposition, but actually that's just to do with where the side branch is there.
Yeah,
I
that's
don't think
right.
that's anything to be concerned about. And again, coming back more proximally, you might want to go a little bit in here. We can see that
Yeah.
there's some.
Yeah, so you
Yeah.
can see there
It's up
that
to you,
the apposition threshold is
I'll
at
remove
300
this for you.
microns,
but you can see.
0.3 millimeters. So you can see that the struts are not opposed in the left main stem. We have taken a 4-5 balloon. Ennis, can you just measure the luminal diameter there on the
There,
left
yeah.
main? So it could be that our pot balloon just hasn't quite reached it.
Yeah.
So that's
Yeah,
4-4. Can
yeah.
you just do in the opposite, in the 90 degrees to that? Yeah, that's good. So 4.
Is it probably just a 4-5 again, Stuart? Eh?
Yeah, I think so.
Okay. And
Take our 4-5 balloon back, and we'll just be a bit more careful, making sure that we get
Sure.
the first couple of struts.
Sure. Okay, so we've checked for dissections at the edges.
You can actually see the stent video. You don't
Yeah.
really need OCT to tell you that the
Yeah.
first strut is just underexpanded slightly, not opposed. So we'll just go in very, very slightly. So just go up there, Margaret.
Yeah, I like that.
That's got it.
Another thing is you're not looking to go to high pressure here because we're not dealing with disease. We're just trying to push the struts back.
In fact, a lot of people would use a semi-compliant
Yeah.
balloon with this at low pressure, because all you're trying to do is oppose the stent. So yeah, that looks good. Start and down. So that's
Looks
come up
absolutely
great, hasn't it?
fantastic. So the angiographic expansion looks great. All the side branches have been preserved.
The
front
ostium
end
on the
of
left
it,
main
it
looks
looks
good.
great, doesn't
Yeah,
it?
doesn't it? Nice step up
Yeah,
into the left
yeah.
main. Held onto the branches, which is good. So that's
Wires
brilliant.
out
I'm
for
just gonna
prettiness.
Take the wires out. We'll do our final picture in this view.
Okay, lovely. Really nice.
So we've got no wire perforations or anything to be concerned about. Our branches are all patent. Stents are well expanded.
Fantastic.
All looks really good, doesn't it?
So really nice example of using imaging guidance in a really difficult case.
Yeah.
Challenging, you know, but the imaging really added to our decision making about the calcium modification, stent sizing, and then helping us confirm, as best we could that we've got a nice stent result.
I think even it's shown as well that even if you can't, the arterial disease is so bad that you can't get the OCT catheter past it all, even getting it partially down the vessel was quite helpful in the LAD, showing us the left main stem.
Yeah.
So all in all, I think using the OCT guidance, using the PCI Assist software to do stent vis and stent vessel vis, it's been really, really helpful.
Yeah, I agree.
Okay, well, thanks very much. I hope you've enjoyed that case. We've got a nice result for our patient. To let you know, his ECG looks perfect. There's no ST shift. His blood pressure's fine. He doesn't have any chest pain at the minute. So we'll just get him off the table now. Probably use an 8 French angioseal to close the leg, and we'll get him back to the ward. Thanks very much.
So after nearly 2.5 hours with 2 experienced operators, we managed to achieve, to my eye, a nice angiographic result. Paolo, can you give us your interpretation of the final OCT images with respect to the MAX part of the MLD MAX algorithm?
Okay. I would like to underline one important technical aspect, I think, that you and Margaret has well shown during the procedure. When you deal with this kind of lesions with loss of calcium, and you prepare in the best way your plaque with NC balloon, scoring balloon, cutting balloon, what you want, I think it's very, very important to evaluate the balloon expansion, changing your projection into orthogonal view. I think it's very important to do this before implanting a stent, because what can be expanded in one view, it's totally sub-expanded or not expanded in the orthogonal view. So this is my comment about your procedure. I think you has shown in a very elegant way this aspect. Commenting your OCT pullback after stent implantation, of course, the OCT pullback from the circ. As you said, we have this algorithm to follow, and the second part of the algorithm is MAX. M as medial dissection, which it means to evaluate where you land with your stent if there are any dissection where next to the struts of the last part of the stent. And as we can see here in your proximal landing zone at the level of the left main, there is no dissection. You landed in a very safe part of the left main. And the same, if we look to the distal landing zone, we don't see any fracture of the intima next to the landing zone. So I think this is the first key point to evaluate after the stenting. The second thing that we have to look is A as a position, and a position, it means to evaluate if there are malapose struts. And as you show in the movie, the software automatically can detect malapose struts with this yellow flag in the longitudinal view. And of course, if we look to the left main, there is a significant malapposition of the stent. And I'm sure that nobody would have said this look into the angio. It looked really perfect, the result by angio, but only with imaging you can detect with this malapposition. And it's very important to detect, as in this case, a malapose stent around 360 degrees in the left main. So this is a very important point. It's a different story in this part of the vessel. Of course, we are not afraid, as in the image in the middle, of 4 malapose struts in a single cross section. It doesn't matter. But as you said, we have to collect all the information that we have. And we know that at this point, and it's indicated also in the longitudinal view, we are next to a bifurcation. So the software automatically can detect malapose struts because the software doesn't see any tissue behind the struts. But as we see, there is no tissue because behind there is the ostium of the side branch. So these are not malapose struts. So very important to collect all the information and to take any kind of decision. And speaking about the malposition at the level of the left main, I have to say that I marry your choice to report with a semi-compliant and not with a non-compliant balloon to oppose better the struts at that level, with a semi-compliant balloon the left main. And I have to say that using this stent vis as a sniper and closing your filter in order to reduce the X-ray radiation and in order to increase the resolution of the image, I think is the best way to be sure of report in the precise part of the stent. The last thing, last but not least, part of the algorithm is expansion. And of course, if we look to your acquisition to the longitudinal view, we can see a gradual as natural tapering of the vessel, and that's really good because this is what we want to see. And if we go looking for the expansion of the stent, we can see that you had an excellent expansion because the software automatically could recognize more than 100 of expansion. For the evaluation of the stent expansion after stenting a coronary artery, with this software, we have two possibilities. As you did in this case, using the tapered reference, that I think is the best way when you stent a long segment of coronary artery. The better way to evaluate is using this tapered tool, while we know that we have a different way to evaluate the stent expansion, which is the dual reference, which it means to divide the stent into two half parts and to compare the proximal half to your proximal referring landing zone and the second half to the distal refer landing zone. So I think it is the best way to evaluate a stent after the implantation, and I think you did a great job.
That's brilliant, Paolo. Thanks very much. So for the first time in my practicing career, I managed to break not just one, but two Dragonfly Optus OCT catheters in the same case. So Giulio, can you take us briefly just through some recent advances in OCT catheter technology, which may have helped us obtain intravascular imaging in this very heavily calcified, tortuous and severely diseased LAD?
Of course, we cannot select the patients. So you got a very challenging case with tortuosity and with a huge calcification. Let's try to have a look to the new technology that is coming in combination with the software innovation. And this technology is much more practical, because to be informed about the calcification, you needed to get into the lesion. And that's where was your problems, because you have all these things. So a new catheter is coming. This imaging catheter has much more pushability, and that was due to a redesign shaft. It's very nice for lesion crossing. That could be an issue. So it has a different taper. So it has a reinforced guide wire port for improved trackability. And finally, the Upstar has also a shorter lens to taper distance. So you can try to get more distally to have some better visibility of the lesion. Here you may see one example of a very severe calcification, and the catheter was easily crossing and having some clear visibility of the lesion. Here, what we got in a severe calcified vessel. So you have the loop running. Once again, when you use this system, you have projected into the angio the orange segment that is telling you exactly in which position you have calcium. And you can see while the system is scrolling that you have a different section with a completely different area of the calcification. So one more time, we are going back. This is upstart confronting with a very severe lesion. You can see different cross-section. On the left side, you have a very extensive circumferential angle that is quantified with a number of 270 degrees. And you have also pointed out by the arrowhead the maximum thickness. That in the mean portion, you can see that the calcium is less. And then distally, once again, you have this vessel that is extensively calcified with a highly significant thickness. And so by this information, we got dilation, high pressure with a non-compliant balloon in the proximal and distal segment, and then we will acquire the images. This is only with a non-compliant balloon, so we needed to understand much more in terms of a calcium response to the lesion preparation. Here you can see the importance to have OCT perform after the lesion preparation. You can see large cracks and fissuring on the left side, and also minimal cracks, but very effective on the mid section and also distally. What does it mean? So that you are judging the preparation by using this type of images. Then you can decide to implant the stent, and here one more time you can optimize the stent not only by intravascular imaging but also by the enhancement techniques. And here is the last point, the last plus of this new type of AE-driven information. So you can compare the baseline pullback, where you can see the lumen and the minimal minimum lumen area, with the final assessment, where you can measure, as Paolo was saying, the expansion. That is something totally new, very important combination of a new, very highly performing catheter with high quality and AI-driven software. Back to you.
Oh, thanks very much, Giulio. That's been excellent. So I'm very grateful for the online comments and questions relating to this clearly very thought-provoking case. I'd like to thank you all for your interactive participation. In the interest of time, I'm only going to cover a couple of things that I don't feel we've covered in the webinar so far. So Dr. Burgess was asking whether you need contrast for stent vis imaging. No, this isn't required, Scott. For stent vis, it's just a 30-frame acquisition. If you want to see the stent in relation to the vessel, you have to administer contrast, and that is called stent vessel vis. But the majority of the case that should be performed there, we only used stent vis. Dr. Islam was asking, do I prefer intravascular lithotripsy in routine management of calcified disease? Not really, Dr. Islam. It really depends on the severity of the calcification. Obviously, IVL works best when there's circumferential calcification, though there is some data recently for eccentric calcium. And it also depends on the lumen of the vessel. It's quite a bulky balloon to deliver, and when you are able to deliver it, it's very, very effective. But obviously, you don't want to open one of these expensive devices unless you're pretty sure you're going to get it to the area that you want to deliver it. So I would only open IVL if you're sure you can get it there, and in your more severe calcified cases. So given that we've ran slightly over time, I'd like to propose the following take-home messages. I'll just show you the next slide. So we are increasingly taking on more and more complex patients with very complex anatomy in our day-to-day practice as interventional cardiologists. There are novel technologies in order to determine our best strategy in how to deal with severe calcification and to optimize the result. Is available with the new OpStar catheter if this is coupled along with the Ultreon artificial intelligence software. Procedural precision and safety I feel is enhanced when we use stent enhancement techniques, such as I've shown with the the PCI Assist software. And there are new techniques for treating severe calcification out there that are highly effective and work very well. So it just remains for me to thank my friend and colleague, Dr. Margaret McIntaggart, for helping me with our complex case. I'd like to thank our panelists, Giulio and Paolo, for taking the time today to join us for this and to share with us their expertise. I'd like to thank my staff and management at the Golden Jubilee National Hospital for allowing us and helping us to do the case. I'd like to thank PCR for hosting this educational event, and our sponsors, GE and Abbott. And most importantly, I'd like to thank all of you for watching and participating online. I hope you all have a very pleasant evening. Good night.